my name is Angelo Kagwa from EVAC, and today I'm presenting voluntary medical male circumcision, the basics. And this is part of EVAC's new PowerPoint series, HIV Prevention Research 101s. So what is medical male circumcision? Voluntary medical male circumcision is the removal of part of or all of the foreskin of a man's penis by a trained healthcare professional. And I would like to emphasize towards here voluntary and healthcare professional, because these men actually volunteer to be circumcised, and they're circumcised in a healthcare setting. And this is very important because there are many other forms of circumcision. So how did we know about male circumcisions? How did you know that male circumcision works in prevention of HIV? There's been a lot of data, observational data over the years that showed that men who are in circumcising communities actually have a less likelihood of becoming HIV infected. But more recently, in 2005 and 2006, there were 3 randomized controlled trials that were conducted in 3 countries of Uganda, Kenya, and South Africa that showed us that circumcision actually reduces the likelihood of men becoming infected with HIV by up to 60%. And even more recently, we know that long-term follow-up of men in those communities actually showed that the effect lasts longer and actually persists and improves over time. So with this evidence, we know that male circumcision actually works to prevent the transfer of HIV from an infected woman to a man. So what's the biological rationale for this? There are 3 main reasons for this. 1, a circumcised penis actually has much less lesions or tears. Once a man is circumcised, the penis hardens, and from that hardening comes protection. The second reason is that the inner foreskin of a man has a very heavy concentration of HIV target cells. So once the inner skin is removed, there is no longer a target for HIV to get to. The third reason is circumcision reduces the risk of other sexually transmitted infections, which eventually lead to or increase a man's risk of getting HIV. What's the current status on HIV, on voluntary medical male circumcision? I've talked about the 3 trials that were conducted in South Africa, Uganda, and Kenya, which gave us the evidence of more than 60% reduced risk of HIV infection. The other thing is that once those trials gave us the results, the World Health Organization provided guidance that now helps in the scale-up of male circumcision in 14 priority countries. So these recommendations came right after the trials gave us the results that I've just mentioned about. And then in 2012, we have seen real-world benefit. In fact, we have seen trials showing that after long-term follow-up, there is protection of up to 76% in communities in Orange Farm in South Africa and in Kisumu in Kenya. And then the other thing that is really important for us to know is that there's been now some research that has been done in the use of non-surgical devices. And there are 2 particular ones that I would like to mention, Prepex and the Shang ring. And as we speak today, there are demonstration projects going on in 8 countries, including Uganda, Kenya, Zimbabwe, Rwanda, and others, where they're trying to see how can we increase the uptake of male circumcision in these communities, in these countries which need to increase circumcision the most, to ensure that we use these non-surgical devices to increase uptake. And also, we're hoping that in early on in 2013 or in the second quarter of 2013, the World Health Organization can provide guidance as to the use of these non-surgical devices. And finally, I just wanted to talk about the fact that in the 14 priority countries, we've only seen 1 or 2 that have scaled up at the pace that we're expecting. Most of the other countries actually are lagging behind, and we need to work around trying to increase scale-up of male circumcision in these countries. So that's it. This only emphasizes the need for us to accelerate the scale-up of male circumcision in these priority countries. And the one thing I would like to emphasize is the fact that male circumcision is a one-off intervention. So once somebody is circumcised, they'll remain circumcised for the rest of their lives. And I emphasize this because many of the other biomedical interventions have a challenge of adherence, which in this case we don't have, because once a man is circumcised, they will remain circumcised for the rest of their lives. And so last year, global partners such as PEPFAR and WHO came up with a goal of circumcising up to 80% of men and boys in these priority countries. And this means that about 20 million circumcisions have to be achieved. In the end, this would lead to an aversion of up to 20% of new HIV infections and save more than $16.6 billion by 2025. It's a very ambitious goal, but we can achieve it, I believe. So the initial target has to be reached by 2015, and then we need to monitor progress and ensure that that is sustained through 2025 to be able to get to this effect. And finally, we need to ensure that medical male circumcision is actually integrated into routine services that are offered, for example, for newborn males, to ensure that it actually, it's part of neonatal care. So I've been talking a lot about the need to accelerate VMMC in the 14 priority countries, and Kenya particularly has progressed so well. In fact, they are past the halfway mark in getting to their target. On the other hand, progress hasn't been so well in some of the other countries. Uganda, for example, is still lagging behind, but many of them are starting to catch up now as we speak. So it is very important to help them to get to that target. So what's in it for the women? You might ask, how does my mother, sister, cousin, auntie benefit from this? VMMC has huge benefits for women, and one of the things that stands out the most for me is when we have less men infected by HIV in the community, we're going to have less women infected in the longer term. And if we look at the goal of circumcising 80% of the men in the 14 priority countries by 2025, we will avert nearly as many infections in women as in men by that time. This is really big, and if we look at the monetary gain in that alone, it is huge, and I just want to emphasize that. So you can see these numbers are highlighted in the graph that I just showed you on this slide. The other benefit for VMMC for women is to do with STIs. VMMC actually lowers the risk of men transmitting STIs. And if we have less men transmitting STIs, it means we have less women, for example, acquiring cervical cancer, which is a leading killer for women. The last thing I would like to say about this is actually a word of caution, and this is to do with the resumption of sex within the 6-week healing period. Men are required to abstain from sex for at least 6 weeks after they have been circumcised. Resumption of sex within that period actually increases risk of acquiring HIV, and it's important that we emphasize that. So what do we need to do now to ensure that we get to the 80% that we want to get to? 6 things that I would suggest. The first one is about leadership and commitment. And this is at the national, the global, and the regional levels. We need our leaders in these countries, in these priority countries, to own this intervention. We need them to step up and get the funds they need from their different ministries to ensure that there is local funding, there is local financing for male circumcision programs. The second thing is we need country-level implementation. Countries need to develop very detailed, very costed, and targets that are evidence-driven. Every single one of these countries has, different needs, and they have a different epidemic. We need to have costed plans that are going to drive the scale-up of this intervention. The third thing is the issue of demand creation. A lot of countries actually do not even know, why are the men not coming to get circumcised? Why are more young people coming to get circumcised than older men? So we need to be able to have every one of these countries to develop demand creation plans that are very specific to every community in that country. The fourth thing I want to suggest is every one of these priority countries, 14 priority countries, must put in place meaningful budgetary allocations for voluntary medical male circumcision. It's not enough to expect PEPFAR and to expect, all the other development partners to come in. We should have local governments allocate funding for male circumcision as part of their national budgetary development, as part of their national budget development process. The fifth thing I would like to suggest is the use of innovative devices to help to roll out, to scale up male circumcision. And with this, for example, there are two non-surgical devices I would like to talk about, and that's Prepex and the Shangring. These, they don't require surgeries, and they're much faster, according to the evidence we're seeing, to be used to carry out a male circumcision. So if countries, for example, consider using these, it might be possible to save funds, but also to save the time that each circumcision takes. So that might actually help with the scale-up efforts. So countries should look at how they can prioritize the evaluation of the sustainability, relevance, and feasibility of employing these new non-surgical devices as part of their scale-up plans. The sixth thing, and the last one, is monitoring and evaluation. Countries must develop a set of standardized tools and indicators to be able to guide their monitoring and evaluation plans. Not many countries have this. So if you don't know what you're going to monitor, if you don't know what you're going to evaluate, it's very hard to come at the end of the program to do exactly that. So we need plans for each country to standardize indicators for evaluation of their male circumcision programs and scale up. I believe that by doing that, we'll be set to get to the 80% goal that we're all aiming for, and we'll hopefully see the end of AIDS. So the last thought I wanted to share with you is that male circumcision, as you've seen, is a clearly effective intervention that could have a very big impact on the epidemic. But it's only a part of the comprehensive response. It's not the one intervention that is going to change the face of the epidemic. But together with the other interventions, we hope we shall see the end of AIDS. Thank you, and for more information, please do not wait to visit the EVAC website, www.evac.org. Thank you.